And now I would like to introduce to you Susan Bold. Susan's going to lead us through the next section of our, our session today, talking about women and Parkinson's care. So, Susan joins us. She's from the University of Minnesota. She is a board-certified holistic nurse who manages patient care within the Movement Disorders Clinic at the U of M. She has extensive experience in working with patients with Parkinson's disease, essential tremor, and dystonia. In addition, she manages the DBS program for the university, leads consensus meetings for the approval of DBS surgeries, manages patient care before DBS workup, and assists with DBS device management after surgery. That's a lot. She also leads patient education classes in Parkinson's disease and deep brain stimulation and facilitates a Parkinson's support group. So we are really happy she could find time in her schedule to come and share some information with us today. Help me welcome Susan.
Testing. Okay, it sounds like I'm mic'd okay. I want to first start out by saying how thrilled I am and honored that I was invited to come and be with you all. Working with Parkinson's patients has been just one of the most wonderful things that's ever happened to me, and I just can't thank you enough. The other thing I want to mention is you will notice I have a tremor, okay? Now, as Liz was saying, when you are stressed, the movement disorder can become a lot more pronounced. So you may notice me tremoring a little bit more because standing up in front of a group of people isn't the easiest thing to do, but I'm going to pretend it is, okay? So, what I'd like to do, first of all, is to circle back and say something that Angela said earlier, and that is today's treatment was yesterday's research, okay? So, the things that we have to help treat you and your symptoms with Parkinson's is because people volunteered to do research. And I just want to point out that in the back of the room by Erin over there, I brought some flyers on some current research that we're doing at the University of Minnesota. And being here with women and Parkinson's disease, I want you guys to be included in this research. I want to have the women's voice so we can finally find out what the differences are. Not sure what to do there, but we'll see how it goes.
We're going to try and bring it down just a level. Maybe it was too loud, we adjusted it.
Thank you. Thank you. Okay. Good. All right. So back in May of 2018, I got to go to Vancouver. And through the National Parkinson's Foundation, I attended the Allied Team Training for Parkinson's Disease. At this conference, which was like a 3-day conference, I learned specifically how centers of excellence work together to help support people with Parkinson's disease. Now, I want to tell you what the difference is and why a center becomes a center of excellence. And it's because all the people, all the players of the team are working together in a very, very special way. Right now, the University of Minnesota isn't quite a center of excellence. We hope to be someday soon. But Struthers is, and they have had wonderful outcomes. And it's because of this. A lot of places have these different allied team professionals working to help you with your symptoms. And we call that a multidisciplinary approach. And we have that at the university, okay? We have all these professionals, and they are fantastic. So we work together. But interdisciplinary care, like at Struthers, is those players are all dating, okay? They're all dating, and they're all equal, and they all know what each one is doing, and they work together in a very, very special way. Working together as a multidisciplinary center, we have at our disposal these wonderful professionals. But we need to get them together and have everybody in a very special, special relationship. So that's what we're working toward. Now, if you have Parkinson's disease and you're a woman, chances are you've only seen your primary care physician. I know I'm preaching to the choir here because you're all here for a reason and you're aware. But most women with Parkinson's disease are not aware. They do not know that the minimum care for Parkinson's disease, the minimum, is to see a neurologist. And so many of them just see a primary care physician. And primary care physicians are wonderful, and they know a lot about a lot, but they don't have the time to specialize. And there's so much that they don't know. There's so many intricacies that are involved in Parkinson's. And so the minimum is to see a neurologist. Now, in a team approach here, let's see. Oh, it even has a laser. Sweet. Okay, so the neurologist. Let's just take the neurologist and make them a movement disorder specialist. Okay? The movement disorder specialist is a neurologist that has had 2 or more years of specialized training in Parkinson's, essential tremor, dystonia, Huntington's, those movement disorders. And so they know Parkinson's inside and out. They can diagnose. They can treat with medications, and they can give referrals to the rest of the team. And here's the rest of the team. And I'm going to end with what the nurse's role is. But when you go to the doctor and you are diagnosed with Parkinson's, you probably don't quite understand what it is each one of these players do and why each one of those players is so important to your best care. Okay? So I'll probably come back to this slide. Okay. So when we say the minimum care for a Parkinson's patient is to be seen by a neurologist, that reduces the risk of being in a skilled nursing facility. And that's because the neurologist, movement disorder specialist, can get you to the team members that are going to keep your function going. Okay? Lower risk of hip fracture, lower risk of dementia-related problems in functioning, and more likely to use all of the other therapies. The movement disorder specialist is very, very aware why it's important for you to see a speech therapist, why it's important for you to talk to the social worker, because they understand the disease so well. A neurologist, a general neurologist, may not know the intricacies and so may not refer you to these other team members. Now, women with Parkinson's, as I mentioned, are less likely to even see a doctor, let alone a neurologist, and they're more likely to be placed in a skilled nursing facility. So I wonder why that is. And I want this to be interactive, so if you guys have any, thoughts, if you just scream out your answer, if you know why you think women are less likely. No caregiver? That's a very good point, okay? So women live longer than men. We know that. And we know that with the generation, women that are probably, I think the median age is in the 60s that you're diagnosed with Parkinson's. So in that generational age, how were women brought up? I think women were brought up to take care of everything. I think Erin mentioned in the last time when she did the exercises that multitasking. Women know how to multitask, okay? They have had to spin so many plates in the air to be wives, mothers, workers, all these things, and hold it together at home. And for generations, we've had to hold that together. And so the last person that gets help is the woman, you know? She is the one who stoically says, oh, you first, you first. Oh, I can't do that because I have to help so-and-so first. Well, I'm here to tell you that you have to put yourself first. You have to. If you don't, you won't be there for anyone else. And I want to tell you that putting yourself first is not selfish. In generations, some women have thought perhaps that they're being selfish, that they're not giving. Well, I have to tell you, if you don't have anything to give, you're going to start losing more and more function, okay? The way we cope day to day in our lives, we have a certain number of resources, okay? So, in other words, if I had Parkinson's disease, I have a certain number of resources. But I want to tell you, I'm not just my Parkinson's disease. I am a social, emotional, mental, spiritual human being. And if I don't take a look at every single part of me, my whole person, something's going to be out of balance. And the resources that I have, I'll be using them and I'll be functioning for quite a while with the resources that I have. But there comes this point where you don't have anything left to give. And what's going to happen is all those things will crumble upon you and things will come out sideways. And you'll start having issues with, who knows, it could be a bad back. It could be more anxiety, panic. It could be a lot of different things. But if you don't take care of the whole person, you're just not going to be able to take care of anyone else. Okay? This is just a slide that kind of goes over. You can see where women fall as far as likely to see a neurologist for Parkinson's disease. Men, they go right away. Maybe it's because their women, caregivers, are saying, hey, something's wrong. You need to get to the doctor. Whereas the woman is holding it inside, isn't telling anybody, or just thinks that it's, I'm just a little tired, or, just poo-pooing the symptoms and just not going in to get help. I don't have time. I've got to do this. I've got to do that. Well, it's so important to get in. Now, because of this tendency for women to put themselves after everyone else, they are more likely to have a hip fracture, and they're more likely to have dementia later in their Parkinson's progression. So what happens is more of them go into a nursing home than men, okay? And so you can see here from this slide that people that don't get help from a neurologist are more likely to go into a nursing home situation. And having a hip fracture or dementia is even a bigger risk factor. Sorry about that. So this slide just shows you that women with Parkinson's have an increased risk of dementia and hip fracture. And because of that, this dementia is associated with a 4-fold increase of going into a nursing home. Now, I don't know if women are going into nursing homes or skilled nursing facilities more often because their husbands are not alive anymore and they don't have people to take care of them, or if, or just that they don't have a caregiver that is able to take care of them. So it's multifactorial, I'm sure. And there's a lot of barriers to both men and women. And I want to kind of go back to the team, because I want to tell you about what the team actually does to help with these barriers. So I'm going to go back to this slide. So let's talk about what does a physical therapist provide in your team approach to care. The physical therapist can work on 2 different things. There's structural issues, of course, that a physical therapist can work on, like if you have a sore back or if you did your ACL in and you need exercises to get that back. But there are neurologic certified physical therapists that help with other things. These neurological physical therapists will be helping you with your gait and your balance. They can help you with dizziness. And that's really, really very, very helpful because a lot of people with Parkinson's have dizziness. And the big therapy, you've heard Dr. Orehek mention Big and Loud. Big and Loud is this therapy that combines physical therapy and speech therapy to help people. And it has been shown in studies to be very, very conducive to maintaining function. So the big portion of that is that movement that's big. And we need to be reminded to move big and to be big. Because with Parkinson's, we tend to go inside. We tend to get slower and more inside. The speech therapist is the other component to that therapy, and that is the loud therapy. So, do you ever notice, or does anything ever keep you from going to social situations? Sometimes people don't want to go to social situations because they feel isolated or they feel different or they feel like they can't keep up with the conversation. Sometimes people with Parkinson's, because of slowed thinking or trouble with word finding, may not want to participate in a social situation because it makes them feel less than. So a speech therapist, believe it or not, can help with that. They can help with swallowing. They can help with soft speech. They can help with stuttering. All kinds of things. If you find that you are coughing a little bit more when you eat or when you lay down, or you're having trouble handling your own secretions, like your saliva, that type of thing, it's time to see a speech therapist. And guess what? If your doctor doesn't mention it, it's up to you to advocate for yourself and say, hey, could I get a referral to a speech therapist? And your movement disorder doctor is going to say, sure. I don't know about your neurologist or your primary care physician, but your movement disorder specialist is going to say, sure. Because this is not a one-time thing with physical therapy. and speech therapy or any of these things. It's not a one-time thing. It's going to be throughout your walk with Parkinson's. Okay? It's important to get an evaluation early on in your journey. Okay? To get that baseline. That's really important. Then they can see what's changing and how it's changing, because every single person with Parkinson's is different. There are no two people alike. So please do not compare your insides with someone else's outsides, because you're going to win by losing every single time. Okay. So the speech therapist, very, very helpful. The occupational therapist, Dr. Arahek mentioned that they can help you with vision things. The occupational therapist can help you with cognitive things too, figuring things out, how to maneuver life for today. And I like what Liz said earlier. She said something about, this is what is going to get me through, or let me live today. And that's all we have is today. So we have to do what we can on a daily basis to get through and live well with Parkinson's. So the occupational therapist, they're going to help you do what you need to do. Okay? Let's say you have real difficulty in the morning with your morning routine, and it is just a struggle, and you don't find that you're able to get going until noon or whatever. The occupational therapist can look at what's going on in your life, watch how you're moving, and say and offer ideas and utilize devices and different things that will help you to manage your life. Maybe it's help getting your socks on, because with Parkinson's, things are slower. Maybe it has to do with just the morning routine. Whatever it is, they're going to help you with that. They're very, very, very interested in safety. And if you have Parkinson's disease, the moment you have something in your hand, that's when you forget you have feet. It's very difficult to multitask with Parkinson's. When I first started at the university, I had a nurse who was training me in, who is a volunteer at the Parkinson's Foundation. She told me people with Parkinson's they really can't walk and chew gum at the same time. There's so much that is involved in thinking and putting it together. And believe it or not, it's the occupational therapist that's going to help you with that. How would you know that unless, your movement disorder provider told you that? How all these team members work together, what they can do. So, the social worker. The social worker is key in that one slide that I was just on about barriers. There's so many barriers to getting the care that you need, okay? And women especially, they might have trouble, taking the time. They might have trouble with transportation. Transportation is a big thing. You may not know what resources you have in your community. You may not be able to have a good meal every day because you can't cut up food anymore, or there's different things that happen. And a social worker is there to help you with all the resources. They can give you the referrals they can give you the phone numbers to who to call, and it's like, oh my gosh, you don't have to do this alone. Life is difficult enough, but especially with Parkinson's, it can be even more difficult. So you've got to have a team that walks with you. And these are the players that should be dating. So the social worker also can help with mood issues. Some social workers more than others I know that at the university, our social workers certainly can help with immediate mood issues and behavior and things like that, but they're going to make more referrals. And the people that you need on your team to help with mood would be your licensed mental health professionals, okay, to help you with that. Which brings me to the psychologist, psychiatrist. And I was in a support group one day, and a social worker who practices therapy said, "Why do you say psychologist and psychiatrist? Because you should be saying licensed mental health provider, because that's what I am." And that's true. That's very true. And what they find is that one of the most helpful things for people with Parkinson's is cognitive behavioral therapy. We can get into our heads so much, okay? And especially due to medications, we can get stuck on thoughts and ideas. And they can twirl around in our head, and we just can't let them go. And it's hard to move on to a more positive thought. Well, cognitive behavioral therapy challenges your thoughts. Some people say, "I don't want to go to a therapist because I don't want to talk about my childhood." Yeah, I know. It's a ways back. And how's that going to help me today? Well, cognitive behavioral therapy, we don't go back into the childhood. We start with now. What are your thoughts? Because your thoughts create your feelings. And your feelings can also move back and create thoughts. So if we intervene on the thought and challenge it and say, is that really true? Is it really true that you can't go to the store? What is it that's preventing you from going to the store? You know, and that's what cognitive behavioral therapy is all about. Challenging the thoughts and saying, oh, well, I guess I could, you know, ask Liza for a ride. I guess it wouldn't be that big of a deal. Okay, well, I'll do that. And then all of a sudden, the sky opens up, and it's a simple fix when you maybe didn't know that. Okay, and a dietitian. Unfortunately, dietitians aren't usually covered by insurance unless you have diabetes or there's some other diagnoses that insurance will cover a dietitian, but Parkinson's disease is not covered. But it might be the best money you spend on something. So, you know, not necessarily having to go every month to a dietitian, but meeting with a dietitian when and if you're having trouble, okay? So when and if you start losing weight, that's key. You've got to get in to see a dietitian. The other thing about losing weight might be something, and you have to tell your doctor about this, because it might be time to see a speech therapist. There might be issues with your swallowing, and maybe you're avoiding foods because you're afraid of coughing or whatever it is. So the dietitian is a very good team member, but you may have to pay for it out of pocket. Now I'm going to talk about the pharmacist. The pharmacist is a huge member of your team. No one knows medications better than your pharmacist. At the university where I work, we have a neurology medication therapy management pharmacist who works with our Parkinson's patients. Natalie is amazing, and a lot of insurance companies cover this. And the purpose is to make sure you stay safe, okay? Less is better, probably. And you know when you have Parkinson's, there can be quite a cocktail, okay? Because every symptom that we have in Parkinson's may require a medication to help manage it. maybe not a different medication for every symptom, but there are many medications in the toolbox that the doctor has. And so the pharmacist, having a consult with the pharmacist maybe yearly is a really great idea, because what they'll do is they'll look at every single medication that you're on, from the cardiologist, the urologist, the ENT, all these different specialties. Who's minding the store? Who is minding that store? The medication therapy management pharmacist can manage and make sure that you're not having any interactions from each of the different medications. And they can also look and see if they can take away some medications. For instance, with Parkinson's, we know that Parkinson's medications can cause a decrease in blood pressure. Okay? We also know that Parkinson's itself can cause some blood pressure issues. But let's say you have high blood pressure for years. Now you have Parkinson's, but you're on 3 different high blood pressure medications to lower that blood pressure. Now you're on carbidopa-levodopa, and whoa, you can't even stay up without falling. So that's what a pharmacist can do. Look at all the different pieces and make recommendations. So some of the people in this room who know me know that I like to use a word picture. And that word picture is a tool belt. I actually asked my boyfriend, I said, do you have a tool belt? And he was going to give it to me, and dang it, I didn't get it. And so I was going to buy one, and I thought, I don't really need one. But anyway, you've seen what carpenters wear, those big tool belts, okay? And they've got their hammer and their screwdrivers and all the different pieces that they need. It's the same way in our lives. Even if you didn't have Parkinson's disease, you need a team to take care of the whole person that you are. If all you have is a hammer, everything's going to look like a nail. And that's not the way life is, okay? You need a hammer for certain things, okay? So you may need that movement disorder specialist to get maintained and get some medication, get something going. But then you need perhaps physical therapy because you're having trouble getting out of bed. And they can help you with ways to get out of bed easier. Ways besides satin sheets, which is a nice option. So that might be your screwdriver. But then you may need counseling because you've got anxiety that is just through the roof. And so you use that wrench for that thing. And basically the nurse is the one in the middle looking at the big picture, looking at how all those pieces move around you. They make recommendations. The nurse is who's looking at you as a person. I mean, every one of these players are looking at you as a whole person. But the nurse is looking at your response to your disease. The nurse diagnoses your responses to your disease. The nurse is the one that has had major training in therapeutic presence. How do we talk to someone who's newly diagnosed? Who do I go to if I don't know anything about Parkinson's? The nurse. The nurse educates you, okay? The doctor has to see patients they've got to stay on schedule, right? It's the nurse sitting at the cubicle with her headset on going, okay, we can do this. I can talk you through this. and we go through and we look at what resources you have. And so it's so important to know what tools you have in your toolbox. Many of you may not know you have tools. And what I want you to know is that living well with Parkinson's is going to require many, many tools. And this is what I've talked about so far is just to let you know how we use these tools, okay? And in an interdisciplinary practice, we would talk about how each one of these players can help each one of you in a particular way. 1 year you may need more support from occupational therapy. 1 year you may need more support with something else. It ebbs, it flows. Life changes, it comes, it goes. You have stressors in your life that happen. And so that's how we walk with you through this challenge. So I'm going to get back to where I was. Oh, those were the barriers. Transportation. So many people don't realize that their insurance actually covers a cab to and from appointments. Who knew? It's great. So anyway, the social worker is very, very helpful with handling barriers. And you've been on an airplane, and I'm sure you've seen the flight attendant. First thing they do is they talk about what happens in case of an emergency. And they always say, put the oxygen mask on first, yourself, then assist those around you. And I want you to realize that that is the wisest thing. It's not selfishness. It's actually the best advice you can have. It's because without your own oxygen mask, you can't breathe and you're done. You're down for the count. No one's going to be there to help the other people. So please, please understand that doing things for yourself is okay, and it's the best thing you can do. So this is just another slide that kind of talks about how women tend to just do the care for everybody else and not expect or ask for the care that they need. And it's very important that we ask for the care that we need, because no one can read our minds. We have to say what we need. And I don't know, women are really resilient. There's something about it. I don't know if it's because we can give birth or what it is, and I don't know, but genetically there's something very, very strong about a woman. And strength is not about doing it alone. Strength is about asking for help when you need the help. It's all about making meaning of this one day that you have. So take care of your spiritual health, whether that's walking in nature or spiritual guide, religion, whatever it is, art. Make sure you're taking care of your physical body. You got to break a sweat and lift weights. Do it. That's the best thing you can do for your future in your disease progression. And for anyone, even without Parkinson's, break a sweat for 15, 20 minutes a day. Do some weight training. Make sure you're doing it with both sides of the body, not just one. Take care of the mental issues that you may have. Challenge yourself. Learn new things. Don't stop living. So, that's what I've got for you today. Lunch.